So this is an introduction to our Dynia project for you kind folks who have agreed to review our virtual patient cases for the chronic pain guidelines. So the Dynia project is all about knowledge translation. I think you've probably been told a little bit about this. This is an adapted PowerPoint that we've been using for informing our rural test sites about what the project is doing. This presentation focuses more on the relevance of the virtual patient cases and what we want our reviewers to look at. So I won't bore you with what knowledge translation is, lots of synonyms for it. The concept's more important than arguing about the definitions, and you guys I think are fairly well aware of this. The study consists of three main parts. There's a short series of webinars about chronic pain issues, the content focusing on headaches and low back pain. There are some linked virtual patients, and I'll come to the virtual patient description shortly, and then there's an online discussion forum, and that's linked to the virtual patient cases and to the webinars. Clinical practice guidelines, as many of us are aware, are a bit of a struggle in terms of, or had a struggle rather, in terms of adoption, and so we're looking at practice-based sessions as a knowledge translation strategy to get some rural practitioners to consider and adopt these clinical practice guidelines in these particular areas. The guidelines we're focusing on are two top guidelines, one about low back pain as mentioned, and the other one about management of headache in adults, and those are the links to them if you want. So this diagram, which is a little bit small I'm afraid, it's basically a little sort of flow diagram. It shows the timeline of the study protocol. We start at the top in green with the site visits, which we completed. The first webinar in pale yellow. It'll be a sandbox. It'll be really just introducing them to the webinar technology, the virtual patients, and getting their hands dirty in terms of playing with the cases. And it'll be a very lightweight topic. There'll be a bit of discussion. The COP Commons branch you see off the side. COP Commons is it's a community of practice commons, and that's basically our discussion forum. We then move on to the first webinar series, and the case series, which will probably be around headache, and there'll be some cases throughout that, and then we move on to a third webinar and case series about low back pain. So the webinars themselves will be between an hour and a half. They'll have short virtual patient cases within them. There'll be some presentations, short didactic sections by the subject matter expert, and they're going to be coached on using learning designs within the seminar, so they're going to be very much broken up by lots of interactivity. This is not the usual sage on the stage, sit and be taught type approach. The cases will promote audience interaction, and we're going to encourage our presenters and our participants to debate with each other. The virtual patients, these are being used across all three components of the session, so there'll be some which are pre-webinar, during the webinar, and post-webinar. So there's 12 virtual patient cases for each topic, so 24 in total. 4 of these cases will be played prior to the webinar, and that's completed on the player's own time. 4 of the cases will be interspersed throughout the webinar, sort of highlighting particular topics that the speaker wants to bring up. The players will play those virtual patient cases in real time on their own machines, just as they're connected on the web, and then so it'll just be a very short case, like taking 2 or 3 minutes, and then the results of the choices made by each player will be shown anonymously, so everyone can compare what they thought and what choices they made after everyone's finished the case. And then after each webinar, there'll be 4 cases released, and they'll be to be completed over the following couple of weeks. And the players can do those, or participants can do those on their own time, and hopefully that should promote some more discussion on the discussion forum. So what are virtual patients? Well, first off, they're not virtual reality. This is not the same as 3D worlds or Second Life and stuff like that. It's really much simpler technology, just using a web browser. It's more about the story, about the narrative, and closer in most cases to sort of like a choose your own adventure. I don't know if you remember those books, but the old storyline of you get to the bottom of page 37. If you want to slay the princess, then go to page 22. If you want to rescue the dragon, go to page 44. Or you could be conventional and do it the other way around if you want, but who wants to save a princess? In our cases within the Dynia project, we're making them much more linear, much less complex, really much more like short snappers, sort of typically just 3 or 4 steps long, but still with lots of decisions and choices to be made within the case. The most important part of the project generally is measuring the behavior change here. We want to see if this combination of activities actually changes how physicians handle these patients. So we're presenting them virtual patients, but the idea is that if you have a challenge, are you going to tackle it differently depending on the information you've had? And to do this, we're using an approach called Script Concordance Testing. We chose that because it's really the only assessment method that correlates well with increasing practice experience. Most other tests actually penalize experienced clinicians. The further away you get from graduation, the worse you do on most exams. But Script Concordance Testing actually benefits those with experience, so that's what's been attractive to us on that approach. This page here shows a paper version of a script concordance test. You get a brief bit of information about the patient, and then rather than picking best of 5, sort of, what do you think is going on here, it's more along the lines of, well, if you're thinking in this case that migraine, and then you find out in that middle column, then you find that the headaches usually last about 2 hours, does this diagnosis of migraine become ruled out, less likely, more likely, or certain? And so it's a weighting thing. If you then move on to for the same scenario, if you're thinking of cluster headache and you find out the headaches usually last 2 hours, so it's the same information there. Is the hypothesis of the diagnosis of cluster headache more or less likely? Then if you have the twist that if you're thinking cluster headache and the pain is unilateral, does that make it more or less likely? And again, for cluster headache, if his wife reports he gets a droopy eye during the headache, does that make cluster headache more or less likely? So it's not guess the right answer. It is, here's some information, here's some further information. How does that influence your thinking? Quite different approach, and our cases to some extent are trying to reproduce this approach. So at this point, I wanted to demonstrate a virtual patient case, but ironically the virtual patient server is down just now, so I'm going to come back to that. A couple of points I wanted to just highlight here, that designing these script concordance cases is quite hard, so this is where we really want you to sort of have test these cases and think about, are they realistic answers, are they realistic choices? We want to move away from the classical best of 5 thinking that you see with multiple choice questions, where one answer is right and the rest are just basically disguised distractors, and there's only one option. In script concordance, all of the options need to be realistic or possible, that reasonable choices that a practitioner might make or might do in real life, and the weighting is a little bit different. So I'll use this next diagram to sort of highlight this. You're comparing the answers not with what the case author thinks, but with what a bunch of experts, i.e. you guys, think about a case, how they would navigate a case. If we depict a case, so I've got 3 cases here just laid out as a series of vertical nodes, and each case starting with the green box up at the top. Now I realize you can't read the content of the boxes, but that doesn't matter just now. So for each of these cases being shown, there are 5 decision points, and this is just very, very simple. So on the left-hand column, this would be a case that would be more like multiple choice question style. The lines between the nodes are meant to indicate where did most people choose. And on that left-hand side, you can see that there's a really thick line in each case linking and moving its way down. and that implies that that everyone chose the same way, and that's kind of what you get with multiple choice questions, or what you should get with multiple choice questions, i.e. everyone's in agreement that this is the correct answer. The difference in script concordance testing is that there should be some variability, that the answers are not complete agreement, that you're looking for some agreement. So if you look at the middle column, the thickness of the arrows, and I apologize this is not a wee bit more clear, but the thickness of the arrows indicates how choices were made. So if you look, say, the middle column on the second set of nodes, you'll see that the two right-hand choices coming down were much more popular than the others. So most people picked the fourth one over, and quite a few picked the fifth one over to the right, and very few picked the others. And the same applies as slightly more spread on the third set or the fourth set. But you have, rather than having a single answer which is dominant, you have two or possibly three, and the scoring is based on how close the player is compared to the averaged weightings or the proportional weightings of the opinions of the experts. That sounds a little bit complex. There's some very good stuff out there on script concordance testing if you want to read into it, but by all means call me if you're interested in hearing more about the complexities of that. The right-hand case is an illustration of what you more typically get. So that very first set of choices, starting down from the green box at the top, you'd have fairly good agreement with the two right-hand boxes on the first choice. On the second choice, everybody wants that far right-hand choice, and that's kind of like a bit not such a good question. It's well, duh, this has to be the answer, and it's kind of like an MCQ question. There's only one choice there. On the third and fifth sets, again, you'd see some agreement, but not everybody agrees. But general concordance that there is some paths which are more popular than others. On the fourth set down, pretty much it's even across the board, that you could pick any one of those and everybody chose evenly. That's not a good discriminator in script concordance testing, but we do anticipate that despite our best efforts, that we will have some cases that will play out this way, where you could pick any of the options and you'd be equally right. And I think we'll just have to live with that. So hopefully that little node pattern thing makes a little bit of sense, just as to what we're trying to achieve here. We will be feeding back to the participants sort of once you play the case, this is how did everybody else play this out, how did they choose, and these stacked bar graphs are indicators. So for instance, of that one particular node, you have 6 choices from narcotic contract through admit for detox down to engage husband pill monitoring, or just information, that they could pick any of those. And if you look at the length of the bar graphs, refer to psychologist is the most popular overall, but they're also stacked, the darker lines being this was the first choice on this occasion. So this is something where they could choose any one of these, not just any one, they could choose as many of these options as they wanted. We want the players to choose them in the order of what they thought to be most important, i.e. their first choice is the one they really would do first or consider most important. So in this particular case, 4 players made refer to psychologist their first choice, whereas 3 made engage husband their first choice, and only 1 made medication review their first choice, and it goes on like that. So it's not just an indicator what's the most popular choice overall, but it's the relative weighting you can see from the darkness there as to which is the more important choice to act on first. Hopefully that makes sense. We've tested this out a little bit on our participants, and they seem to like that approach, but we will be testing this out further as we go. The discussion forum is linked to the virtual patient cases. This is a secure area where they can not just discuss how they handled the cases themselves, but if there are similar related clinical issues that are they'd like to discuss, they can also put those into the forum as well, although we will be discouraging them from using identifiable patient information. Okay, the subject matter experts can also answer questions posted on the boards there. And so that's about it. So that's how the things all integrate. This is a quick list of our project team members and our subject matter experts, but do get back to me if you have any questions about how this works and what we're trying to do with our virtual patient cases. Thanks again for offering to test them out.